Okay, now they can hear.
Okay.
Sorry, everybody. Sorry about that, Daniel.
That's all right. Hi, everybody. Nice to meet you. I hope you can hear me. So far, I've introduced myself and said what osteoarthritis is, and that exercise is important in clinical practice guidelines, but this meta-analysis suggests that actually exercise maybe isn't a panacea. It does recommend that multifaceted interventions should incorporate exercise, and given my background and given the title of the talk, it's probably no surprise that I believe one core part of a multifaceted intervention should be sleep. And I've been working with this conceptual model, I guess, really simple, but physical activity or exercise can help with pain management, but I've been working under the assumption that that might be moderated or modulated by how someone is sleeping or the presence of sleep disturbances, whilst bearing in mind the really complex causal web of all of the other factors that might be impinging on someone's biopsychosocial experience of their condition. So using this model, I'm going to talk through a couple of studies that I've conducted to test the tenability of this. Because if this is indeed supported, it would indicate that we should be considering including an evidence-based sleep improvement intervention into exercise or physical activities for osteoarthritis pain management. Now, I will say that advice about sleep hygiene is included in some exercise interventions and in routine clinical care, but we know that's not enough to resolve sleep disturbances and disorders. So the first study I want to talk about was conducted with a cohort of adults aged 50 years and above, and I wanted to see whether or not the presence of disturbed sleep changed the effect of how physically active they were on the likelihood that they would go on to report pain in the future. So this is a group of people without pain at baseline. And this was inspired in part by this World Health Organization report on ageing and health. So in this document, it talks about how important it is to remain physically active as we age and to meet the public health guidelines about how much moderate or vigorous physical activity we should be doing. But I searched throughout this whole document and the word sleep didn't appear once, which stands in contradiction to my model that I'm working with. And I've spoken to Mara this morning and a couple of other people about how I suspect it's because we hold a tacit societal agreement that sleep simply just deteriorates with age. It's just a case of aging. But actually, that's just not the case. It's not what we see in large epidemiological studies. There are reasons why sleep does decline or deteriorate with age, comorbidities, polypharmacy, nocturia, for instance. But actually, if we look at the National Sleep Foundation's recommendations for sleep duration, you'll see that older adults, defined as 65 and above in this figure, really require the same amount of sleep, essentially, as an adult of any age. So it's not the need to sleep that declines with age, but the ability to. So I think we're underserving older adults if we're not thinking how we can help them sleep, particularly because we know that poor sleep is associated with a range of deleterious health outcomes. But just to go back, the hypothesis for this study was then sleep is essential for healthy aging, should be included in this book, but it's also a condition within which the benefits of physical activity can be optimally reaped. And the aim specifically was to identify whether sleep disturbances modify the association between physical activity level and the likelihood of going on to report troublesome pain in the future. So for this study, I used the health and retirement study data set. So this is a large cohort study conducted out of the University of Michigan's Institute for Social Research. So they conduct interviews in households every 2 years with adults across America, across the contiguous United States, who are aged 50 years and above. It uses stratification, clustering, over-sampling of minoritized groups to make sure that with sensible design-based analysis using the weights within the survey, that the findings that we have can be related to the population level, so the full American population. So just to reiterate again the model, I was looking at baseline, people with no troublesome pain. I wanted to look at how physically active they were at that time, using questions about their time spent in moderate, vigorous or light physical activity and creating a physical activity index score. I wanted to look at their sleep disturbances at that time at baseline too. So that used 4 questions from the Jenkins scale, which asks about problems with sleep onset and sleep maintenance, such like insomnia type symptoms, waking earlier than desired, and also feeling unrefreshed and unrestored on awakening. And then I look forward 2 years later to see who went on to report having troublesome pain of this pain-free cohort. So around just under 10,000 people in the health and retirement dataset reported having no troublesome pain, these people 50 years and above, in 2014. So with the sampling weights added, this represented a sample of around 50 million US adults. And we can see in the pie chart here that just under a third of the sample reported having sleep disturbances most of the time. 46% reported having sleep disturbances sometimes, and 22% rarely or never, so the smallest group. In the sample, just over half were female with a mean age of 67, and of those without pain at baseline, 19% went on to report troublesome pain. And as would be expected when we looked at a kind of just simple main effects analysis, lower levels of physical activity predicted going on to report troublesome pain, as did more frequent sleep disturbances. But pertinent to the research question, adding the interaction term between sleep and physical activity did indeed show that there was a synergistic effect. So for the group who had no sleep disturbances at baseline, higher levels of physical activity at this time were associated with a decreased likelihood of going on to report having troublesome pain 2 years later. The same direction, the same type of association was seen for those with some sleep disturbances. But for the group with frequent sleep disturbances, higher levels of physical activity weren't only non-protective of going on to report having troublesome pain later, but it's actually associated with an increased likelihood of having troublesome pain. So why might this be happening? Well, obviously we know that sleep has a physical and psychological restorative and recuperative function, and if you're not getting that sleep but you're being more highly active, you may be not having the time for recovery, you may be having an overload response. Also, we know that sleep deprivation or sleep fragmentation in experimental settings is associated with increased levels of pain sensitivity. So it might be that you're more likely to go on to report pain if your sleep is disrupted and you are doing more physical activity. Now, we don't know that people in this cohort, maybe they've got more manual jobs doing more labour type work, but there may be reasons why we're seeing this pattern. But certainly if this is upheld in future study, it would suggest that any other studies of the association between physical activity or exercise and pain may be really masking true effects if the effects of sleep haven't also been taken into account. Now, having said all of that, although this did really address the model that I built, I will say there are obvious limitations with this data set. It's entirely self-report. There's this 2 years between the baseline and the follow-up where anything could happen, and we know pain fluctuates. Lots of the questions weren't the questions I necessarily would have asked. There might be some measurement imprecision, and it is a general population sample. But I would say I did do a sub-analysis of the group that reported having a kind of generic arthritis and did find exactly the same pattern came out of the analysis. But on the back of this work, I thought, well, I want to do a study where I address some of these limitations and focus specifically on the clinical population that I'm interested in, people with osteoarthritis. So in this study, I wanted to measure physical activity and sleep in a more objective way, so using wearable technology. And I wanted to look at a day-by-day type of association. So how you sleep one day, does that have an impact on next day, whether or not physical activity is more pain relieving or not, given that we know that people with osteoarthritis are told to be active and engage in exercise. So the hypothesis here was that after nights of higher sleep efficiency, which is good, higher levels of physical activity the next day would be associated with less pain. Conversely, nights of lower sleep efficiency, the benefits of physical activity wouldn't be as pronounced. And I just want to explain what sleep efficiency is here, just to make sure we all understand. Sleep efficiency is a measure of how well you are sleeping, which is defined as the proportion of time you spend in bed actually asleep. So if you're in bed for 10 hours and you only sleep for 8, your sleep efficiency is 80%. So actually we would all hope to have around 90-95% sleep efficiency would be great. You certainly want more than 85%. So I used a wrist-borne accelerometry, the triaxial accelerometer, to measure, to get an estimate of sleep duration and sleep efficiency in this study, which is used alongside the sleep diary to make sure we were measuring the right sleep construct. Physical activity was measured with this accelerometry too, and the device we had an interface where we could ask about their pain intensity throughout the day when they could put the number on. So on a scale of 0 to 10, what's your pain now? We asked that 5 times a day and got an average each day to get a kind of rich assay of their pain. So in this study, we had 116 people with osteoarthritis with a mean age of 64. 60% were women, the vast majority were white, and their pain severity was mild to moderate on average. We had a measure of sleep, the Pittsburgh Sleep Quality Index, which asks a range of different questions and can measure sleep quality. And we can also then, using their scores, categorize people as having poor or good sleep. And we did find the majority just of this sample could be described as being poor sleepers. We looked at sleep efficiency over every night for every person in the study. We got a median of 80, which again is suboptimal for sleep efficiency, and at the lowest level of 36% sleep efficiency, which is really dire. But this does match what we know about people with osteoarthritis having comorbid sleep disturbances. So having done the analysis, we found a very similar pattern to what we found in the large population level study. So on nights of poorer sleep efficiency, so the less steep line, next day, although there was an association between higher levels of physical activity and lower levels of pain, it wasn't as pronounced as after nights of higher sleep efficiency. So the better you sleep, the more pain relieving exercise seemed to be the next day. So this, in combination with a couple of other studies I've done looking at other sleep and physical activity metrics, is supporting the inclusion of an evidence-based sleep improvement intervention into an exercise program for people with osteoarthritis-related pain. But that does raise the question then, what would be a good evidence-based sleep improvement intervention to include in such a combinatorial approach? Well, the main issues that people with osteoarthritis report related to sleep are symptoms of insomnia. And the American Academy of Sleep Medicine, as well as learned societies across the world, all recommend as first-line treatment cognitive behavioural therapy for insomnia, over and above any kind of pharmacological approach. So CBTI, as it's called, is a multi-component treatment package which includes psychoeducation, so helping people learn about sleep factors that influence it and how they can change their behaviours to increase the propensity to sleep. It includes cognitive restructuring to help address unhelpful thoughts and beliefs about sleep. And it has very key behavioural aspects. So one is stimulus control therapy, which is where you want to get the person to reassociate the bed and the bedroom with sleep and sleeping only. So if they're not asleep after 5 to 10 minutes and they're tossing and turning, the advice would be get out, go to another room with dim light, read a book, do something relaxing, and when you start to feel your eyelids getting heavy, then go back to the bed. So you really want to get that conditioning back in place. The other behavioural aspect, which is arguably the most potent but also the most difficult, is sleep restriction therapy. So this aims at trying to increase or optimise someone's sleep efficiency. So say you are in bed for those 10 hours, but you're only asleep for 6, your sleep efficiency is going to be 60%. It's not great. So sleep restriction therapy would say, well, then let's go to bed for 6 hours. And so you can try to increase that sleep efficiency and then slowly stretch it out over time whilst hoping to keep the gains of that sleep efficiency. So thinking about CBTI, it has been historically delivered by a clinical psychologist on a one-to-one setting delivered over kind of 8 weeks. But research has looked into different ways of delivering the intervention in groups, over the telephone, using apps. And there is one app developed at the University of Oxford called Sleepio, which is completely automated. So you'll see there's this little professor here who takes you through all of the content. There's an algorithm that underlies that matches the content to what you need. Although it was developed at Oxford, the spin-off company or the parent company now has offices here in San Francisco too, as well as London. So it's an international product. It's been shown to be effective at resolving symptoms of insomnia across now actually 13 randomized controlled trials. And because of the way that it's automated and delivered over the internet, it's really flexible, has potential for scalability, and can be accessible to people that may not otherwise have had access to CBTI via a psychologist. Because there are limits of the amount of psychologists that can deliver it, but also thinking about the prevalence and the increasing prevalence of OA. If this is going to be a useful intervention for these people, we do need to find different types of tools that can be scaled. And testament to that, I will say that in the UK, this is the front page from the Times, alongside Tom Cruise, is the front page news that now doctors, informed by the NICE, which is the kind of regulatory medication and therapy organisation in the UK, are now saying that they're able to prescribe this on the National Health Service, and it's being conducted across the whole UK. So we know this is a scalable solution. So, thinking this would be a great intervention to put alongside an exercise intervention for people with osteoarthritis. So I developed a working relationship with the team behind Sleepio, and they agreed to work with me to see if we could develop this new combined intervention. Because notably, one of the RCTs does not include osteoarthritis, so it can add to their portfolio as well. But if we're going to develop this exercise program around Sleepio, it then raises the question, what should that exercise program look like? So the next stage of this project was to really involve the target users in that intervention development process, really to optimise the acceptability of the product, make it as attractive as possible, but also to increase the likelihood that this would be disseminated in the future, taken up and really implemented in a sustainable way. So we really wanted to find out, do people want their exercise to be delivered in a group? Do they want it to be one-on-one? What should it look like? So we conducted a longitudinal kind of focus group study with people with osteoarthritis-related pain and sleep disturbances, where we showed them the Sleepio product, we told them what we wanted to do, we showed them some of the research we were doing, and we said, explain, we want to know what would be the best physical activity intervention you think would work with this. And we use this model here in the hexagon of wanting to find out what kind of language we should be using, if there were any tools to help motivate them that they thought we should include in the intervention, if they wanted feedback when they were going through the programme, and if they did, what that should look like, if they wanted their progress to be tracked, and again, how that should be operationalised. A really key part of this was working out how the physical activity or exercise component should be delivered to make it as attractive to as many people as possible. And related to that, we wanted to know if people wanted social interaction with their peers as they were going through the programme. So after the first round of those discussions, the research team went away and we developed prototype materials for the intervention. And then we invited everyone back to see if they could give us their feedback on what we'd done and help us to refine and develop even more. And nearly everyone came back, which is great. You never know what's going to happen, so that was fun. And they then helped us go through and work out how we should refine what we'd already worked out. But we did record all of the conversations from those focus groups and then analyse them thematically to identify what may facilitate, what might be a barrier to the intervention, and also, quite key, what should be the characteristics of the physical activity component. I would say in the facilitators category, motivation was, ubiquitous. In all of these kind of themes we found motivational language, motivational accountability, so having some kind of health coach to check in to help them to kind of feel that they were making progress. And also this motivational education, they wanted to see that there was some tangible evidence that the intervention might actually have an effect on their pain rather than going on it blindly. I would say, as far as language goes, what we found was similar to what has been seen in other chronic conditions, which look at physical activity or exercise. People just don't like the word exercise. One participant said, when I was a kid, when we were in PE class and we did something wrong, we had to run an extra lap or work out extra. It's like punishment. But it should be a gift, like health enhancement activities or something. It's got a bad taste in my mouth. Exercise. They talked about softer words like move, movement, motion is lotion, things they'd heard in other types of contexts when they were being encouraged to exercise. When it came to education, they were really clear. They wanted to see the studies. They wanted to know that we had some research that shows achievable, quantifiable results. So a lot of pressure. But it did mean that when we were thinking about putting together some kind of manual for people going through the intervention, we could include some introductory material to show we've been doing some work in this area. There's a good reason why we're asking you to kind of help us to determine whether this is a sensible direction to continue to go down. With regard to barriers, we did find that often these were people who were slightly older with osteoarthritis and sleep problems, and they did feel that they'd been patronised in healthcare environments before, with one saying, they're saying, "Oh, you're doing so well," and it's like in their voice for someone your age, and that kind of stuff. It really ticks me off. So it really helped us start to think about the atmosphere of the intervention, the people we train to be health coaches potentially to help with accountability. What should they be communicating like? What should the ethos be? Obviously, we're researchers, we want to record sleep, we want to record movement and physical activity. And lots of these people had taken part in research before or interventions. And once they understood the need for that, they didn't like this notion of recording behaviour. They thought it was quite burdensome and disruptive. The fun saying it gets overwhelming, where it's like, I'm going to throw up my hands and say, screw it, forget it, I'm not doing this. So again, I'm not sure we're addressing that so well because we do want to capture as much data as we can, but I think it's really important to bear in mind that it can get in the way. And there were some barriers around uncertainty about technique. So when we were talking about the physical exercises or activities that they might do in the move part of the programme, people would get confused and they weren't always things they really understood and they didn't feel confident to do. So we took that on board too. But with regard to the characteristics of the physical activity part of the intervention, and you'll notice I switch between saying that and exercise because the exercise isn't an enjoyed word, so I try to avoid it. But they did want it to be as tailored as possible to their own individual context, so it could be sustainable. They wanted it to include resources that were close to them, that they could continue to use, and support networks that they had access to. So really thinking about this as a long-term behaviour change, and not just participation in a short-lived exercise programme. So the next stage, we map these themes onto known behaviour change techniques, which could be incorporated into the intervention or the intervention manuals, and informed by the feedback and work that we did with the participants in the focus groups. We developed the Move and Snooze programme. So this combines this course of Sleepio alongside a 6-week course of behaviourally graded physical activity improvement, which includes identifying an individual's goals, helping them to achieve them through action planning, and addressing things like barriers. But introducing strengthening exercise is an important part of a programme, but touching on the importance of sleep here because already thinking ahead about a potential trial wanting to include some kind of sleep hygiene in a control arm, but also thinking about how this can be sustained in the future. So in this intervention, it's fully remotely delivered. A health coach meets with the participant once a week and goes through each one of the content. There's manualised workbooks that people work through, and alongside this, they're also going through the Sleepio programme. So obviously the next stage was to conduct a feasibility study, because I thought, well, that seems like a lot of therapy to give someone, and a lot of it's self-management, self-directed essentially. So we did conduct a feasibility study, and the findings were really promising. By definition, everyone in the feasibility study had to have at least moderate levels of pain related to osteoarthritis and had to screen positive for insomnia using an instrument called the sleep condition indicator. So you'll see on the insomnia symptoms graph here that everyone was below the red line at baseline. That was literally an eligibility criterion. But by mid-intervention, the average was subclinical insomnia, and by the end, nobody would have screened positive for insomnia. We did see reductions in pain intensity, not as marked, but I'll explain why we think that is on the next slide. But overall, this looked like initial promising evidence for the Move and Snooze programme. And we did, at the end of the feasibility study, conduct interviews with all of the participants and analyse the interview transcripts, and did find 4 themes of a general perception of benefit. People really did like the intervention. They found the snooze or sleepio component, and specifically that sleep restriction component, challenging, but worth doing it. They did feel like it was worth the outcomes they got at the end. They felt the coaching was pivotal. They really enjoyed the one-on-one time spent with the coach, although that does raise the question of sometimes it might be that particular coach that was good, so we need to look at how we're going to manage that in fidelity manuals. But also there was one theme around the lack of relevance as a reason for non-engagement. So this feasibility study included people with both knee or hip osteoarthritis. The people with hip osteoarthritis actually tended to have more progressed or more closer to end stage osteoarthritis and weren't really participating in the physical activity component, as it wasn't something they really felt they were capable of at this stage of their disease. So that really helped us to refine who this intervention is for. It probably is more appropriate for people with knee osteoarthritis and maybe even more appropriate for those early stage knee osteoarthritis. But I would say another reason for lack of relevance was the Sleepio program does focus on psychological factors which are related to the symptoms of insomnia, so worries about sleep, rumination about sleep. And they wanted more information about the sleep and pain association, so that gave us an indication we needed to include more of that content, both in the workbooks but also in the coaching sessions. Now, one thing we did consider when designing the intervention was whether or not the sleep part and the physical activity part should be given in tandem, or whether they should be sequentially delivered. So maybe address sleep first and then introduce the exercise program. Now, there's obviously a time-related issue. It doubles the length of the intervention, but I think really our preliminary observational research showed that it looked at there were synergistic effects. So that's why we decided to deliver both at the same time, and that was supported by some of the quotes we got from the post-feasibility study interviews, such as this one person said they felt it was beneficial to do them together rather than stagger them, because your physical activity definitely has an impact on how well you sleep. They really liked the holistic nature of the intervention. Many talked about going to different clinical providers for different aspects. They liked that we were addressing both their physical activity and their sleep in this one intervention. One person said it goes back to the issue of, we always compartmentalise everything. So here we're integrating two different aspects and it's affecting you. And another said it really made me think about how little I was moving and my sleep. So it is quite a holistic realisation of what I was and wasn't doing. So the thematic analysis also raised some other issues that we were able to think about before taking this to trial. So when I talked before about stimulus control therapy, so when you're not sleeping, go up to another room and come back, asking someone with osteoarthritis of the lower limb to do that can actually aggravate their symptoms and make it even less likely they're going to go back to sleep. So we're working with some behavioural sleep medicine specialists to think about other ways we can operationalise stimulus control therapy, such as moving on a different side of the bed when you're awake, even turning a pillow or sitting up. So having some kind of cue or conditioning to help to really get that stimulus control therapy working as well as it can. As I mentioned before, they really enjoyed the coaching, and we do think that there's a real opportunity for the coaches to support people through the sleep restriction therapy part of Sleepio. Sleepio is generally not done with a coach, but because we have got coaches, we can provide that support. And for these people with osteoarthritis, during the sleep restriction, it can sometimes cause some symptoms to actually increase because of the reduction you're doing and some of the worries people have. So we think that that's a really great opportunity for us to include that in the coaching manuals. I mentioned before about hip osteoarthritis maybe not being as relevant, certainly if it's more end stage, so we're thinking more carefully about who to include in the intervention. And we got some really practical feedback about making some of the materials more user-friendly, including having digital and hard copy options for people. Now, alongside this work, I am really interested in the sleep and pain association and underlying mechanisms. And I did, in 2019, publish a systematic review of all of the studies that have applied specifically mediation analyses to identify what factors might lie on the path between sleep and pain. And so this review identified the factors on this slide, so mood, fatigue, attention to pain, pain helplessness, and symptoms of depression and anxiety. But I would say overall this literature base is relatively low quality. Most of these studies are cross-sectional, even though they claim to be mediation. There's no real time in this, so it's really just correlation. But it certainly provides putative mediators that we can look at, and indeed we collected information on these factors in the feasibility study to see if they were moving in the direction that we thought that they should be. And generally they all were. So we did see reductions in fatigue during the intervention. We saw increases in positive affect. And we saw this initially really interesting inverse U shape in pain vigilance. But if you remember, I said that the sleep restriction therapy happens mid-therapy. that we actually see that that can increase the vigilance and it goes down again. And this is a phenomenon which is actually well known in psychology, which I wasn't aware of, so it was good to see that come out from the data. We also saw an indication of reductions in anxiety, depression, and negative affect. So overall, I built this evidence of the original observational studies, some of the qualitative work, and then this feasibility study, and felt, okay, this is ready to put through to an RO1. And I'm happy to say the RO1 was funded at the end of last year, so we'll be conducting a large nationwide trial, because this is all fully delivered online, of the move and snooze intervention compared to the move aspect only, under the assumption that matches the clinical practice guidelines for exercise alone. So the primary aim of this is really to determine whether or not adding a sleep improvement intervention into an exercise program for osteoarthritis helps and is superior for pain management than exercise alone. But we'll also be looking at 4 pre-specified potential effect modifiers. So the first one is actually the extent of insomnia. So is there a level or a threshold of insomnia above which we should be giving people the extra sleepio type content? So we'll be able to determine if there's an elbow above which we should be doing that. We'll also be looking at depression or anxiety symptoms as potential moderators, as it's certainly possible that people with higher levels of those psychological symptoms might need more intensive psychological support as they work through a program of CBTI. And I'm also interested in pain mechanisms, so we'll also be looking at nociplastic pain as a possible moderator of the effects. And the final aim of the RO1 then is also to look at potential psychosocial mechanisms by which the interventions have its effects. So we've got our putative mediators, and we'll be intensively collecting data on them throughout the course of the programme to try to answer some unanswered questions about the relationships between sleep, physical activity, and pain. So I will say I am currently in the startup phase of this trial. We're not yet open to enrolment, but we will be soon. So if anyone knows anyone who's 50 years and above with osteoarthritis, sleep problems, only knee for this one, please do reach out. We will be very pleased to screen and include people. I want to acknowledge everyone that's worked with me on my studies and where I've worked in developing this body of work. And I want to thank you very much for inviting me again and for listening. And I'll be very happy to take any questions if you have any. Thank you.
Just a reminder, if you want to ask a question, remember we need to use the mic, okay? That's right. Go here and then pass down the chair.
Thank you so much. It was a really fascinating conversation. And towards the end, you talked a little bit about the association between pain and sleep. And I'm wondering for your intervention, so just as a personal note, I have rheumatoid arthritis, so I've had pain and all those issues for decades at this point. And when I have the biggest sleep problems is when I'm in pain, when I can't move, when the inflammation is really high. So I'm wondering if you talk with people about that when they're talking about sleep, if you do anything to help mitigate the pain so that they are able to sleep better and able to exercise more.
Yeah, it's a great point, and that was one of the type of feedback we got after the feasibility study. I think one of the things I think about is looking at medications people are taking and when they're taking them, and really trying to make sure that if they're taking taking pain meds at night time, if they're not actually also stimulants. I mean, there's all sorts of kind of crossover there. So I think one key thing will be the notion that pain itself is arousing, and that might be something we need to intervene on. But I guess the hope is that if we're finding the benefits of the physical activity on the pain management, that we can find ourselves in some kind of virtuous circle. But I think it's an open question, and certainly an area for more work.
Hi, excuse me. Thanks for the interesting talk. It sounds like your feasibility study was done a little while ago, maybe more than a year or two ago, I guess. I'm just curious if have you been able to follow up with any of those people to see how their reaction to pain has persisted over time after participating in your study?
It's a good question, and I haven't. I did go back to them when we published the abstract. I haven't been back to them since then, so I think it's a great idea. We'll say in the trial we're doing 6-month and 12-month follow-up, so we will want to look at durability of effects there. Yeah.
So I don't have any questions online yet. If there's any more questions, then we can just continue here.
Thank you so much. This was a great talk. And I'm thinking about a comment that you made early in the talk where you said that there may be differences by occupation, that you may be picking up some physical activity that's related to your occupation.
Mm-hmm.
And so in your measurement, are you able to distinguish who's going to the gym and doing some self-care and that's their physical activity versus somebody who has a very physical job and sort of can't avoid physical activity?
Yeah. We will be collecting information on the physical activity programs that people design themselves. I will say that for those in very physically demanding jobs, I wouldn't classify that as exercise. It's not time they're structuring to do this kind of health, kind of behaviour management, or health supporting activity. So, but we will be collecting information on occupation and looking at that as well as potentially mitigating some of the positive effects.
So we do have a question online now. So I'm gonna oh, I'm trying to unmute her. Can you unmute yourself?
Great. Each time I unmuted, it was muted again for me somehow. Maybe my question wasn't off to a good start. So thank you very much for this great talk. I'm an orthopedist and I also work in health technology. So both of these fields, great intersection. I'm wondering if you could tell me, have you looked into other types of applications that we're using quite widely with our patients right now, such as Omada Health, which has many of the components that you're talking about, but even reaching out to them if you're interested in researching the data that they have that might add to or reinforce the work that you're doing, but with different types of devices. So that was one question. Another one is the type of tracking device you're doing. So the passive tracking obviously is the easiest for patients. That device I was looking, was it an actigraph? Because some of them don't give user feedback. And we found in our work that when patients don't get, can't see their data from their trackers, that they tend to drop off usage a lot faster. So sorry if I missed that point.
Yeah, no. So I'll do the second question because I remember it. It's more proximal. I think there was an ActiWatch in that study. That was secondary analysis of data that a collaborator collected. So I didn't choose that. But yeah, that they didn't get feedback. I think for the moving snooze trial, we're going to use a Pro Diary, it's called, because it has the accelerometry with a more sophisticated user interface to ask ecological momentary assessments. I personally don't want them to see their physical activity feedback in this. I think that I don't want that to be an influencer. And I think as well we've seen, although moving kind of symptom in the sleep area, there's this kind of phenomenon where people get so addicted to what the watches are telling them they're doing, it can actually cause more anxiety. But I think it's really about, if many people may be also wearing their own wearables or they'll be tracking their own physical activity, we won't be asking them not to use them. But this is much more, I guess, for us to capture that data. As far as Omata, I'm not aware of that, so I'd love it if you could follow up with me, and I'd be very interested in hearing more about that.
I think she's meeting with you later. So I'm gonna read a question from Bob Hyatt online. If a person has mild osteoarthritis and mild pain, but is already having good sleep efficiency, let's say 90%, is there any evidence that pushing through the pain to increase physical activity is harmful?
I think the notion of pushing through the pain sounds harmful to me. I think the question here around is when you stop exercising, how quickly does any pain over and above your normal joint pain resolve. So it should kind of, resolve quickly. It should be something that persists. So I think definitely is something to work with your clinician as you're going through that. But the recommendation is physical activity is and exercise are good for pain management. So I would never push through and not listen to what your body's telling you. But yeah, there is some soreness expected.
Are there other questions in the room? There's no others online right now.
Hi, thank you for a really interesting talk. I was curious about your experience working with a company, like a tech company, for doing an intervention, and just wondered if there were any particular lessons learned or surprises that you experienced as a researcher coming to work with a company like that in terms of developing a research-based intervention.
I think I've been really lucky. They've been really, really open. I mean, I think when it starts, I knew about the product, I wanted to work with them. You had to put in this kind of proposal and wait to see if they would do it. And at that time, it was tied into my fellowship. So I was like, this is going to be the hinge around which I might or may not be able to do the project. But the time they took to get to it, it was completely reasonable. But it's a little bit longer because they've got other forces impinging on them to kind of produce what they need to do as part of their business. I will say they've been amazing. They offer really great, because they're based in the UK, they offer amazingly affordable intervention with an RO1 budget, so that was great. I'm at the stage now where I'm just working through all the contracts with them before we can really kind of kick everything off. So that's been the biggest part, but I think that's, again, as friction free as I think it ever gets. So I think it's a really great company. I can't speak more highly of them.
So as you can see on the chat, Patty Cox is going to unmute and ask a question from online. Please.
Hi, Daniel. It's Patty Katz. How are you?
Good, thank you. Hi, Patty.
So I have a couple of questions, and I apologize if I missed this first one. What kind of exercise or activity are you prescribing to people is the first question. And the second question is, are you going to look at sedentary behavior? Because you may get, I'm just wondering if you'll get as big a signal from just reducing sedentary behavior as you will from, activity, and how you're going to measure that. So,
yeah, no, both great questions. So the exercise intervention is a behavioural graded approach which is focused on the individual's goals to really make it personalised to each person. So it really could be something as simple as a 70-year-old woman might want to walk around the park with her dog twice a week, and if that's her goal, that's her goal. Someone who is younger might want to run a marathon, and we're going to have to meet people where they are. It does make it slightly more complex. There's not one single prescription, but it does mean that it's hopefully going to have an impact on people's lives. The second question, remind me again.
sedentary behavior.
Oh yeah, no, absolutely. I mean, I definitely see sedentary behaviour as a different construct to physical activity. I know the work, particularly done by Daniel White, has been showing that sedentary behaviour might be a stronger predictor. So yeah, we will be capturing that using accelerometry and also looking at sedentariness as its own construct.
Thanks. I look forward to talking to you later.
You too.
So I think we have time for one more question in the room, if anyone has a question in the room. Okay, I can read, has a comment, I don't know if you can read it in the chat there. It says this project involves research and co-development, so your agreement with them should include IP considerations for your novel inputs as well.
Yeah, I'm joking. Yeah, this is what we are going through this at the moment with the contracts and where the lines are drawn. So we will be having these discussions. There's lots of red lines on the contract. So, yeah. But thank you for keeping my nose to the grindstone.
Well, it is 12:59, so I think it is time to draw this to a close. Thank you, everybody, for coming, and thank you for everybody being online. I see a great turnout of folks, and I know you have meetings with some people here, and they're continuing as the day goes on.
Thank you very much. Thank you.
Thank you.